I do think we'll get things started. We have a good gang here, both as audience and obviously a terrific dialogue about to start. My name is Steve Bloom. I work at the Yale Alumni Association, and I am also a Yale alum. Delighted to see all of you here and for us all to share an informal and yet extremely meaningful discussion on health equity and the pandemic. I will not be doing the introductions. We have the privilege of having Cheyenne Huang, who is vice chair of our alumni board, to do that. Before we start, just a reminder to everybody, first of all, that these events on Thursday nights are sponsored by the Yale Alumni Association and by many other parts of Yale, depending on the topic. Secondly, they are intended to be an informal dialogue. I'm sure Esther would agree that we welcome thoughts, and even if it appears that there's a dialogue going on, if you have a question, absolutely put it in the chat, and there'll be a chance for you to ask personally that question. The chat will be a trigger for hopefully having you unmute and ask the question in person. These Thursday night events happen all year long, and they are in 4 channels, as we call them, with episodes like this one. It's a dramatic use of the word to call them an episode, but one channel is the STEM report. That's tonight. We also have the human experience, and we also have career pivots and life and personal growth. And we hope you'll listen to as many of those different topics and as many Thursday nights as you would like. You can settle in with your jammies and a cup of wine if you want, but you can also join however you want to join. So they are intended to be informal discussions. Without further ado, let me ask you one more thing. Kate, if you could just put on the screen, we have a 4-sided tile that sort of shows the latest 4 events. In this case, it'll show you tonight's event and the next 2 on April 29th and on May 6th. And we urge you to keep track of these at the Yale Alumni Events calendar, and also just on your own calendars. So Kate, thanks for doing that. You can unshare that. And let me now introduce Cheyenne, who in turn will introduce Esther. Cheyenne is a fantastic alumni leader, a great friend, a wise person, and she will be introducing Esther for our discussion on health equity in the pandemic.
Great, thanks, Steve. I also want to thank you and Kate Gustafson. Welcome back from your break. And Chelsea Gladu has also been helping us to put this event together. Also, I want to put in a short, brief plug in for our own club because Esther and I are both dialing in from Portland, Oregon. David Frackleton is our current Yale Club of Oregon and Southwest Washington club president. Even though we're 3,000 miles away from New Haven, we're a very active club. For years, we've had this event series of luncheon with a speaker in Portland, Oregon. And in fact, I think Rob Greenlee remembers before the pandemic, we were the pioneer club of doing what I called multimodality events, where we had Zoom and an in-person group of people eating lunch. Often the speaker would be on site, and remote speakers, remote audience, so that we can serve our alumni everywhere. And the year before the pandemic, we actually did a whole year series of featuring local Yale women speakers for 9 months, including Esther. Esther was going to close out our series for us. Our series included people who were professors, physician leaders, an Olympian, a law school dean, and others. We are, even though in Yale term, we're the no flyover zone, we are active and loyal Yale alumni. So we're very fortunate, and thanks again for David Frackleton for helping me put this together to have our own Esther True Dr. Chu is a professor in the Center for Policy and Research in Emergency Medicine at Oregon Health and Science University. She graduated JE 94, MD 01 from Yale, and has her MPH from Oregon OHSU. She's a practicing emergency department physician, an NIH-funded investigator, and co-founder of Equity Quotient, a company that provides metric for healthcare culture. She's a science communicator with frequent appearances on national, international networks such as CNN, MSNBC, and she writes a regular column in The Lancet. I'll talk about that later because I'm super impressed about that, Esther. So I think we're going to divide this hour into 3 parts, Esther. As you know, this series is CLY, the STEM report, but not everybody in the audience are necessarily physicians. So I wanted you to kind of not necessarily give you your normal Grand Rounds lecture, which has a lot of great information, but kind of, conceptually tell us how to think about the issue of healthcare inequity and how can we approach that. The second part is my tangentiality, because I feel with 2 Asian women physicians here, if we don't talk about the recent anti-Asian violence insurgents, I think it's inexcusable. While we may not have the answers, I want to hear your thoughts where we can get started. And then the last part, we hope to leave 15, 20 minutes for our friends on Zoom to ask you questions. Does that sound okay?
Yeah, that sounds good to me. And just for people who are attending, we really talked about this as being interactive. And so, and I do give a lot of these kind of talks, and the questions that come from the audience are always like 10 times more interesting than anything that I plan to say. So it's not an interruption. We really would like to incorporate that. And I also think that if we don't get as far as we wanted, but we get to like the last 20 minutes, we will try to really wrap it up and turn to questions so that we can delve into things that are definitely of interest to you. So ask away.
Great. Okay, so let me begin. So the title of your talk is Health Equity and the Pandemic. So, so how do you define healthcare equity, and what's the difference between equity and equality?
Yeah, I think, Sherry-Ann, I don't know if you want to use the slides. I use a very like kind of colloquial definition of health equity because it just helps me. There are a lot of really beautifully phrased and very long formal definitions out there. But when I walk into the emergency room every day, I think of health equity as something that I can operationalize. And then the other half of my job is I'm a researcher, and I also want to know how to define it there. And so this is kind of how I think about it. I just think health equity in practice is when every single patient could walk into the doors of their health facility and just have this confidence that they were respected and cared for to the best of our ability. And I will sometimes add in there that every patient should feel like they are cherished by the healthcare providers. And so that feeling is so key, and it's patient oriented. But I also think that then when we look at key outcomes, we find that that is statistically true, that we have achieved equitable health outcomes. And we tend to toggle back and forth between equality and equity, but I think in general, equality is kind of everyone gets the same. Isn't that fair? Which is totally not acknowledging that we don't all start from the same places and get all the same stuff throughout our lives. So we have to acknowledge that there is advantage and disadvantage, or vulnerability or lack of vulnerability, or privilege or lack of privilege, that there are so many things, which is, why public health people say there's health equity in every policy, but there are just many stacked vulnerabilities that come to play by the time they come to us. And so achieving equitable outcomes doesn't necessarily mean that every resource has perfect equality. We have to be nimble and figure out how we shore up resources for different populations so that there is equity on the other side of it, on the health outcome side.
Great. I think
yeah. I'm sure somebody has a better
that makes sense. But I mean, this is also kind of what we've been learning in the bigger racial discussion, right? Equity versus equality. So thank you for that. And then using what you've learned data during the pandemic, what are some of the themes of healthcare inequity that you've discovered?
Yeah, I mean, I'll say that there was nothing particularly surprising about the inequities that have played out. I mean, back in February, the minute that we knew that the pandemic was coming to the US, people who had studied pandemic, I don't include myself in that, but really smart people that I knew who had studied pandemics over time were like, in every pandemic, it is inequitable. The case rate, the severe illness, the deaths are inequitable, and all the resources that you need to take care of a pandemic are also gravely inequitable. I mean, across the country and around the world. And so they're like, we will see inequities, many inequities in COVID. And what I learned, I learned many, many things from this pandemic. And there were ways in which, as it played out, it was kind of worse than even we anticipated. But what I learned is that we are not set up to even detect inequity. So the really frustrating thing for those of us who were interested in how the pandemic was affecting different populations potentially differently is that we didn't even have very good race or ethnicity data on any of the pandemic outcomes, so that we knew for sure what we were dealing with and could try to address it as we moved forward in the pandemic. So it really took until almost summer in the pandemic, late spring and early summer, before we had COVID case rates broken down by race and ethnicity in the United States. And it's just something I've never really thought about. When we have an emerging illness, like what is the data that we collect? And it turns out the data that we collected was broken down by age categories, and that was pretty much it. And you just could not get this information. So while we had very strong hypotheses, and in smaller populations, like you could get information from maybe your hospital or a health system, and we could see that there were very different case rates across populations. We didn't have that data in aggregate or across the nation, so that we could begin early on to have very specific conversations about how to allocate resources or how to make sure that we built in equity into our COVID response. And so the way it played out was, and I'll just say, like, as someone who studies a lot of health inequities, there are inequities that are subtle, where you get like a large sample and you adjust for a lot of factors and you find this tiny little odds ratio or relative risk ratio that's different, and it's there for sure, but it's not easily visible until you do a sophisticated analysis, or at least some sort of in aggregate analysis. And then there are inequities where, like, if you were in space and you look down and you can see like a couple of man-made structures, you could also see this inequity. Do you know what I mean? And like COVID was the latter. It's like these inequities were not subtle. They were huge inequities. I mean, if you look at the death rate in Chicago, there's something like 6 times the death rate among Black citizens of Chicago than white citizens of Chicago. I mean, just like if you look at age-adjusted death rates across the whole population, you saw that if you were Hispanic or Latino or an indigenous population, or if you were Black American, the rates really over time were well over 2 times death rates. So, I mean, these were not subtle things. The minute we had data to see them, we were seeing them, and the more data you got, the bigger those differences were. And then I'll just stop there. I'll just say that these were striking health disparities.
Great. I think Jeff Rubin, who is a local Oregonian, a friend, brought up a really good point in the chat that disasters don't create inequity so much as amplifying what's there, right? So I think we're using the pandemic data to talk about this issue. But I think the reason why we booked you is really, this is going to transcend healthcare beyond COVID. So how can we approach this? I think you're talking about so in terms of inequity, we need to look at the inequity in outcome, but also what are the other factors that contribute to the outcome? Is it access to care? What are the potential contributors that you've studied? Maybe you could share with us a little bit.
Yeah, totally. I mean, COVID has been So COVID has been really like the exemplar of inequity, because everything that was there played a role in COVID exposure, case rate, your likelihood of having severe disease, and then your likelihood of having a poor outcome, either very severe disease, extended hospitalization, or death, or, you know, sort of extended poor outcomes and disability. And I will say, you know, at the very beginning of the pandemic, a lot of our conversation was on differential incidence or prevalence of chronic health conditions, because we knew that if you have heart disease and diabetes and obesity and all these things, you were likely to have a poor outcome. And we spent a lot of time, but the truth is, like, if you look at the whole person, not just like their chronic disease history, but you really look at every single thing, the way, you know, where you live, what your job is, what transportation you take to work, how much you know, family wealth you have, how much stored up reserve, financial reserve you have, your communities and how healthy they were, what your how far you have to travel to get groceries, whether you had a work from home option, whether you felt like when you had an exposure, you could really do, or got sick, you know, got a positive test, whether you could actually take that time off from work, or whether that meant that you would lose your job, you know? And so all of these things, and actually I have another slide, I don't know if it's like too much, but I have another slide that's sort of how I've kind of conceptualized it, because the more you pull these things apart, the more it became really obvious that it's like, what are the causes for these big inequities? It's like, it's everything. It's like fundamentally the way that we set up society. Sorry. So it's like, you know, I know this is a lot here, and I am fundamentally opposed to too busy slides. And so this feels a little bit against my principles. But I will say this is very simplified compared to what I came up with initially. But I feel like manages to convey, if you just kind of march through all these things that influence your exposure to virus, your susceptibility to contracting the disease and getting severe disease, how quickly you're able to access care, diagnoses and treatments, and how much you're included even in the evidence base. It's like, you just can march through and be like, okay, that's differential by race, that's differential by race, that's differential by race, every single thing. It's like, so it has to do with, you know, it's like, how many policies contributed to the way that the pandemic created these health inequities? It's like, you know what, housing policies contributed to this, incarceration policies did, you know, education policies did, employment policies did, you know, the way that we support our workforce. We had a caregiving crisis that disproportionately affected women and women of color, access to healthcare, the way that we insure people. I mean, just like everything. So you take all of these systemic inequities, built-in inequities, they all contributed to the way that this pandemic played out, because it was such an important part of this pandemic for you to actually have resources, to have certain types of job, to live in, even to live in you know, a housing structure that allowed you to isolate. I had so many patients in the ER, you know, the ER of course makes these things very obvious, but you know, I had patients in the ER where I was like, you've been exposed to coronavirus, and I think your symptoms are consistent with it. I'm going to test you, but until that comes back, I need you to isolate. And I had a family who was like, well, we are a family of 8 people. There are 3 bedrooms, and it's very small, and we all need to share a bathroom and share a kitchen. So how would you advise that we do that? I had that same family come back after they had 2 positive tests, and a 3rd person was getting tested. And what they told me they did is they took a bunch of garbage bags, and they cut them open, and they taped them all together, and taped that up in the hallway so that there was like a sick passage and there was a well passage, just to try to keep some separation. But they said, but you know, Dr. Chu, like, we still all have to use the same bathroom, the same kitchen. And they were trying to figure out they had set up shifts for that. But the bathroom shifts were really tough. So anyway, I mean, and then there's people who are like, I appreciate that you would like me to not go to work for 10 days. However, I need to feed my family. So can you tell me how I can feed my children who will starve in those 10 days and still follow your advice? And they're just like looking at me like I'm a huge idiot. And of course, my advice is ridiculous. It had no place in the context of their lives. And the best thing I could do was just take a whole bunch of face masks and like kind of stuff them in their bag, you know, which we had a shortage. So it always felt a little bit bad, but they were clearly going to work. And so, I mean, there are just things where there are so many structural barriers for for people to keep themselves, their families safe from COVID. And, those were the things that we saw every single day in the clinical setting that were not fixable in the moment, that we clearly need to be committed to fixing in the future. And I would say, so all these situational things, all these historical things that created different vulnerabilities to COVID. And then, of course, you come to the health center, and this is a whole other talk, but you come to the health center and the way that we allocated resources, testing, PPE, timely testing, I should say, testing and then timely testing, personal protective equipment, medications, all of that demonstrated disparities. And now we're into vaccines, and we are giving vaccines out in highly disparate ways. And so it's been so hard to course correct in the moment because we don't have habits of equity. And so we just keep perpetuating it on to the next, whatever stage that we're in, whatever resource is desirable, it is being distributed and received in inequitable ways. And that is the society that we live in.
Yeah, I think you've touched upon the social determinants of health, right? So these again highlights the fact that COVID just brought a lot of these thoughts to the forefront, but also topics that some of us have been thinking about or reading about for a long time. One thing I also want to add, it's not just the inequity during COVID is not just around COVID care, right? As a cardiologist, what I'm seeing is inequity in access to care to me. For example, when we were all going virtual, there are people who delayed care, who also have severe cardiovascular comorbid conditions that cannot wait. And now we're seeing the consequences of their inability to get non-COVID care, but that they need. I think we're starting to see some questions. Next, I want you to kind of lead us through, as you discover these inequities, how should we think about addressing them during COVID and moving forward?
Yeah, I mean, I think there are, we're still not out of it enough to really do the debriefing, the post-mortem. But I think there are some things that are that are obvious already that we need to fix. I think one, I'm a researcher, and so I'm always going to harp on the data, but it's we can't fix or address what we can't see. So really, I think we need to be set up to look for inequities is one thing. And I think also our goal can't always be speed. At least not while we don't have habits of equity. I actually think that you can build in equitable systems until they are habitual, until we have, I just call them habits of equity, until we know how to execute equity and everybody knows how to do that, and that is what is natural. I think at some point we'll get more and more efficient, but right now we don't have habits of equity. And so there seems to always be this choice. We can either do it fast or we can do it equitably. You're seeing that right now with vaccines. So what is the reward for states? What is the goal for states? It's get vaccine out as fast as possible, So it's I know we are all talking about equity, but there's no reward really for doing things equitably. So many states are not even tracking. It's very hard to find publicly available data on the equity, on how, and I'm not just talking about racial equity. It's a dashboard where what communities have been hit the hardest, and so what are the vaccination rates against that? What is your COVID vulnerability index, which is something that's new that can be used on a public health level, and of the communities that have I always forget, is it the highest one or the lowest one, whatever, of the communities that have been hit the hardest or the most vulnerable to COVID, how are we doing in those communities? Because we should be we should be allocating vaccine in a priority way. But we it's we don't we don't get any reward for being high achieving in that way. And if there's no incentive, then we simply don't go where there's no incentive. And actually, there's kind of a penalty for pausing and trying to do things more equitably, because you have to use up your vaccine to get more, and so people who are being confronted between get it out to mass vaccination locations, spend it down fast. Those people are getting more supply because they've shown that they can use it. And we really despise the idea of vaccines sitting around while people try to do outreach to, say, traditionally harder to reach communities, or go into rural areas, or go to, bring vaccine to people, because not everybody has transportation. Bring vaccine to people who cannot sign up online, because not everybody has access to digital means to sign up. It's like doing all those things that we believe in when we talk about it. Those take time. And that just means that you can have vaccines sitting around, and that is seen right now as like a cardinal sin. And so something that, we'd love to see from the administration is, yes, track speed, track vaccination rate, but also provide some metric of equity so that we can see the speed in the context of how you're really trying to penetrate underserved populations in this time, so that we can understand that there may be a trade-off and that those things are both valued, because we've just been laying kind of inequity on top of inequity, and that doesn't feel good.
Great. I feel like I've seen your slides that talks about, I think, at least 4 touch points in terms of how you address inequity. And I think you've maybe covered a couple of them. But there are, let me, now I have to find your own slides for you.
Equity.
Well, the systemic change in organizations to think about race in not only how we deliver care, but who we choose to deliver the care, and I think, yeah, I think you say it better in your slides. Let me find it for you.
That sounds really good to me. No, I mean, I think there are studies that show that there is something powerful about clinician concordance, racial concordance, gender concordance as well, actually. And there's specifically a study that shows that if you randomize, say, Black patients to a Black provider versus a white provider, the uptake of a number of preventive health measures, including accepting the flu vaccine, is higher. And is higher than if you have a non-racially concordant provider. And one of the studies show that if you extrapolate that out, you could actually eliminate almost 20% of this really tenacious gap in cardiovascular health between white and Black men. And, so I think we all understand that racial concordance can be very powerful in delivering better health outcomes. And there's studies that show if you have a gender concordant provider, you can actually, your survival after a heart attack is improved. You come into the ER and there's an ER doc there who is gender concordant for women. I would say for women, your chances of survival. It's not like I feel better taken care of because there's this wonderful Asian lady there. We used to just look for satisfaction. Do you just feel more comfortable? But the studies now look for hard outcomes like, did you live? And when we look at the did you live kind of questions, people actually do better with a gender concordant provider. But that one of those studies actually also looked at just the diversity within the group. And if you have greater diversity, the whole group rises, the performance of everybody rises. And I think that's really what we're going for. I don't think we're headed towards a future where, you boop, 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 put in your stuff and you get matched with this completely concordant provider. And that's the way that we do medicine, just to make sure you get the best of care. But I do think that we are really appreciating in aggregate to just bring in, recruit in, maintain, cultivate a much richer body of healthcare providers is better for the communities that we serve, because healthcare workers do not look like our very diverse general population. So I think that's one of those long-term things that we really have to connect to. Oh, look, there it is.
Yeah, so I have to explain to the audience that I told Esther, I said, no, don't bring your entire deck for grand rounds, just 2 slides. And now I'm asking her to go back to her slides because I really like these touch points. You talked about the workforce diversity, structural factor targets and measurement, implicit bias, training, awareness. Do you want to talk a little bit about that? I mean, I think.
Oh, yeah. I think so that study, so I actually am not sure where I was headed with that exact conversation, but I think my point here, if I brought up that particular study, was that we shouldn't have knee-jerk approaches to building culture, to building multiculturalism in medicine, because when we, I don't know if it's true for all your industries if you're not in healthcare, but in healthcare, like we really have seen like implicit bias training as like the holy grail for making people aware of their potential biases and really try to prevent them when they walk into patients' rooms, and like be aware of their potential for biases against, their patients based on gender or race or sexual orientation or disability or, a wide range of things. But what, the question I've always had is like, these implicit bias trainings feel great. And we all do them. I mean, at my hospital, we seem to do them almost yearly. I've taken mine 5 times. I feel like at some point I should probably teach this course, but you walk out and you feel great. And then I've always wondered what changed? Like, are we demonstrably better now that, somebody like me has been through this training 5 times? Am I a better doctor now? I would like to know. And the truth is we don't measure the interventions that we do to try to build more equitable environments. We tend to just go for that nice kumbaya feeling on the inside. And we don't actually ask the same hard questions that we do of our healthcare interventions. I mean, when I deliver stroke care, when I take care of a stroke patient, you should see how we have like developed 10 million really fine metrics for what quality of care is. I mean, this, like, if my potential stroke patient gets the CT scanner 5 minutes later than what the quality indicator is, I have an email in my inbox waiting for me, saying, hey, you didn't meet your quality indicator. And yet we do all these things to try to create physicians who don't, who aren't racist in their practice, who aren't sexist, who deliver equitable care, who are aware of their implicit biases. I am not sure that the interventions that we do impact our practice in any real measurable ways. And that's actually the studies that are out there suggest that you might perform better on a test, or you might be slightly more aware of these concepts. But when we look at hard outcomes, how do your behaviors change? There's very weak evidence that it translates to different behaviors. And I think that makes sense if you think about it. It's like, how do you continually make something unconscious conscious? Just by willing it to be so? It's like by definition unconscious. And like when we try to correct just the right amount, I think we find that we don't have really good calibration tools for that. So I'm not saying implicit bias training is bad. I just think, I think as much as possible, we have to stop imploring individual people not to be biased or racist or whatever it is. And we have to build systems that don't constantly reinforce racism. I mean, we are discovering all these structural things in healthcare that COVID is really, again, bringing out, like pulse oximeters are racist, like they actually are more inaccurate at detecting hypoxia. Especially as you become more hypoxic if you have dark skin, because these oximeters were not designed for people with darker skin. And there's kind of a continuum. The darker your skin is, the less likely these pulse oximeters are to detect hypoxia when it exists. And I'm so sorry.
He is very mad about
this. Dog, so I don't know his language and I don't know how to make him be quiet. Where was I? Oh, pulse oximeters. So, and the reason this is like such a big deal in COVID is, you may know if you're in healthcare, or you may have heard that we made in situations of very limited resources. So when we have very few hospital beds for COVID patients, 1 degree of change in your pulse oximeter determined whether you went home or whether you stayed. And a bunch of COVID treatments, like remdesivir, one of the first medications available, that's a parenteral medication only. So you only are eligible for that medication if you stay. So if we're systematically under measuring hypoxia in darker skinned people, then they don't have even the opportunity to get some of these medications. And so, it's like, how do I say, a well-intentioned person who doesn't want to treat my patients differently, I still work within a system that gives me certain tools, including a pulse oximeter. And if the pulse oximeter is underserving a section of my population, then I am also underserving them and being also completely unaware of that. So it has to be individuals, but it also has to really be scrutiny of the systems that we operate in. And, of course, that whole thing brought up the way that we recruit people into clinical studies, which is also, that's another whole realm. If you looked at, if you ever pull up the original phase 1 study for the Moderna trial, just pull up table 1, which is the demographic table, and look how many people of color are in it. And actually, this is another, you can see the problem from space. If you look at table 1, there's a whole bunch of zeros in the racial and ethnic categories. It's like no demographic table should ever have that many zeros, because you should have recruited somebody into one of these major categories. Forget disaggregating by racial subcategories. And the really depressing thing about that was that we know from just our history with clinical trials that phase 1 studies tend to be the most diverse. And so if that's where they started, it really boded poorly for phase 2 and phase 3 trials. But Moderna got a lot of good feedback about that, and they course corrected for phase 3. And of course, I may be going on too long, but anyway, who we recruit into clinical trials, the public understands right now whether or not they were represented in clinical trials. And there was a lot of sentiment when the vaccine came out. Very reasonably, people were like, I do not see myself in these studies, and therefore I don't know if this vaccine is for me. So it fed directly into receptivity and lack of earned trust.
Yeah. My goodness. Great answers. Great talk. So time flies. My goodness, it's already 5:38. So let's go to audience questions. We have, maybe we'll start with Shannon Buckmaster. You're bringing up a lot of good points and questions. Maybe can we have you on audio and video so that you could ask your own questions?
There have been so many great points of discussion. I'm going to have to scroll back up through the feed to see what my questions were, because of course the conversation continues to advance even as these are popping up. So we know that socioeconomic, geographic, racial inequities exist. We could have predicted them. Instead, we're reacting to them. And so I wonder how that's also affecting the allocation or the distribution of resources. And so I work in economic development for a government organization. And so one of the challenges is, how do you reallocate the resources available to start to adjust or compensate for or amend the inequitable access to healthcare treatment and the resulting effects, things like job loss, housing, all of these issues. You mentioned that you bridge different worlds, right? The healthcare world, and then also the private worlds of the patients that you treat. And sometimes it's surprising, or it's a disruption to what we expect would be available for a home lifestyle for managing the virus and what actually is the truth. So if you could just comment more on what the adjustment is, or how you see solutions so far into the pandemic now of how we can start to make reparative efforts. I think those were the general gists of where I was going with those questions.
I remember seeing your question as it came up, and yeah, thank you for that. And I will just say, it's like in this moment, it's so clear that we need to really invest in people's lives, that we need to have housing policies, education policies, all these things that make it easier. So let's say the next crisis comes around. It's like, what do we want people's lives and resources to look like so that they can keep themselves and their families safe? And I think there is actually so much good intent right now. There was a care.com survey that said that I think something like 98% of employers right now understand that we're in a caregiving crisis, and their number one initiative for the next year is to expand supports for people who have caregiving responsibilities, whether it's for children or other family members, so that people are able to stay in the workforce, so that they don't have to, so that they can attend to their family lives and still have a job and not have to worry about their job security and still be able to thrive. And so I think we're all sort of being like, so we need people to have to have security, to have access to healthcare. There are a lot of these really, really long-term things. But I'll say, what we grappled with at this time last year in particular, and still do, is like in the acute setting, how do we allocate resources equitably? So just as one example, there was an article in the New York Times, in the New England Journal, our New York Times, in the New England Journal of Medicine about an ethical guideline for allocation of scarce resources. This was kind of in March and April time period of last year where, New York hospitals were running out of ventilators. They're running out of ICU beds and all these really basic resources we needed to take care of the sickest COVID patients. And we didn't know how to make those ethical decisions in the moment. Here in the US, we tend to not run out of even like really advanced care resources. And so, they were like, here's an algorithm you can use. And it's based on like the likelihood that you'll survive, because if you have a really low likelihood of survival, you probably shouldn't, kind of waste resources on that. We should figure out algorithmically, just through a calculation, who is most likely to be able to get out on the other side. And part of what goes into that calculation is the chronic illnesses you have. And if you look at chronic illnesses, because of all the societal factors that play into developing and having poor control of your chronic illnesses, which then can lead to other chronic illnesses, that would basically mean that we were systematically allocating those resources in a way that was so inequitable based on race and ethnicity, And so what do you do in that moment? And those conversations are super uncomfortable. So I was on the ethics committee for my hospital, and we're like, reviewed all the literature on this, and we're like, there are a couple ways to do this, and they do not feel comfortable. But I think we should do them. Like things like maybe we should correct backwards by race, because we know that there is a difference, like sort of a way that based on race, this calculation will be systematically stacked against you. Should we have a racial correction? That feels a little uncomfortable. I think the uncomfortable thing is we can recognize privilege and disparity, but correcting it always feels bad. Because if you're giving up a little bit of your privilege, it feels unfair fundamentally. And so I don't, in my hospital, we never really had to use some of these things, but we are very conscious of the fact that part of the equation, we never wrote it in math, but we were basically like, it has to be a layer of discussion that if we are treating somebody of color who is in our hospital system, who statistically, will have more of these kind of negative scores in their risk category, we need to really pause and talk about that with our ethics committee in the moment about how we might be perpetuating and exacerbating inequities. But I will just say that like correcting for it, especially in an acute crisis situation, are easy ways, are simple algorithms that we throw up there will perpetuate inequity. And we have to resist that and at least build in very self-aware pauses and allow people to sort of like talk through it and think of it and think of ways to correct for it. But I'll say right now, it's not easy and it's not comfortable.
So I asked permission for a quick follow on, and you're going into this territory, but now that we understand how we've increased the inequity, how are we adjusting it? Part of that is looking at the reformulation. One of the questions that I did ask is, are we starting to track beyond age grouping metrics, how COVID is affecting the different populations by different metrics, but then are we starting to apply that math in a systemic way so that when we have our next public health crisis, we're not repeating what we've done?
Yeah.
Is there any concerted effort right now that's taking us out of the acute response and moving us into long-term preventative adjustments?
Yeah, that's a really good question. I think it's all kind of a process. So it kind of depends who the we is. I would say nationally, no. And, states actually release a lot of data broken down by multiple demographic factors to the CDC. And many of the states are like, we release it to you, but we don't release it for public consumption. So CDC actually has a lot more data than they're able to post, because states determine whether or not data, say, released by race or ethnicity, is for public consumption. And CDC can't just post it, because if they do, they risk having the states cut off that information. Some states are really comfortable with it. So Colorado, for example, has a very sophisticated dashboard that they, I think at some point will publicly release, where they have multiple metrics of data by census tract and by county, kind of reporting out what is the racial, breakdown of that of that zip code or whatever, what is the, SVI, the social vulnerability index that incorporates race, what is, what were the COVID rates, all these metrics. And then next to that, post the vaccine rate of that population. So we can really see, are vaccinations matching some of these indicators? And if not, then they feed that back to their vaccine program and try to put more outreach towards them, is the idea. So there are some states that are being really innovative. It takes a lot of commitment from leadership, because this is a hugely resource intensive thing, and just a lot of people who are super dedicated and innovative. Are we doing that in a concerted way across states? No. And in fact, there's a lot of conversation around equity and goals, but there isn't a lot of operationalized equity. And this is not just like in the United States, this is really becoming a global conversation. But I do think there are people interested in like figuring out how to get this right, so that we don't stumble and look like total incompetent jerks the next time this comes around. Because right now at this point in America, people want to talk about equity. And I think the heart is there, and we're just kind of realizing it's very hard to operationalize in a moment, in a very complicated moment with limited resources, something that we honestly have not been that dedicated to, and you can tell because we don't have these skill sets, and so I'm working with a friend on a website where we're just like taking anybody can give us examples. Like we have a little library built up, just examples of how you have operationalized equity, and we're just going to post it there. And we have almost no metrics for that. So we're trying to work with actually some other Yale grads to figure out how we can create some AI instruments to try to troll for different types of metrics based on geography, and align them with what has been implemented there, and try to, for future use or even for ongoing use, try to really give people, well-intentioned people, some tools and examples so they can find something that they can implement where they are with their populations, with the resources and the, that are available to them, rather than just all of us trying to make up stuff. This feels kind of good. Let's do that, which is really the environment that we're in right now, is like 1,000 different approaches to this.
Very interesting, Esther. So we only have 11 minutes. I cannot believe it. No, great points. I want to give it to the option of your roommates. Do they want to make a point or ask a question? They have priority. Elizabeth, or do you have more roommates on this talk, on this Zoom?
Okay, first of all, I was just smiling because jerk is a very Esther word to use. So I love when you said that. I don't know, I guess one thing I'd be interested to hear you talk about is, I don't know if this is more in the category of politics or alternate reality, but I think, as we all know, the previous administration dropped the ball on things they could have done to, address this pandemic better. And I think we've all seen since the change in administration that the vaccine rollout has really speeded up. And, there's still, as you pointed out, equity problems. But do you think it's worth thinking about, or do you and your colleagues think about what might have gone differently if we'd had an administration in place that had been more willing to, promote the use of masks, or, all the basic things that we now know make a huge difference?
Yeah. We have this thing in ER, like the worst thing in an ER doctor's life is when you come in for your shift and somebody says, oh, that patient you took care of in the last shift, and they tell you like all the horrible things you did wrong, and they have the benefit of hindsight. And so we have this whole thing about you don't Monday morning quarterback your colleagues. And so it's so funny because like, of course, I have like many things to say about the past administration. I have this built in from like 20 years of being in the ER, this thing about like, you still don't Monday morning quarterback, like, but yeah, I definitely have like literal dreams, where I wake up and I was like in a meeting with Hillary Clinton, who was the president, and we were talking about like this COVID task force thing and like how we had to hit hard and move the Defense Production Act forward, and we never had a PPE shortage, and and we were like all harmonized around resources and around messaging around PPE, and like it's like when this new, and just like a couple of basic things. I mean, just like, not assuming that everybody's politics are the same, but like, the Biden administration, from the vantage of somebody who does a lot of healthcare communication, so engages with people, in the administration around messaging and around, just emerging science and around PPE supply and health equity. Sitting in some of those rooms, it's like, it's like they'll have a press release, where they'll talk about the CDC is doing, or the J&J vaccine, I'll say. It's like the day the J&J vaccine was put on recommended hold, it's like we were all sitting in a room, I think maybe like 50 healthcare providers who have been doing messaging, and representatives from the Biden team, just sort of talking about what does this data mean? What's likely to happen? What are the ways that the media is already getting the messaging wrong? What are the better ways to communicate this? What do we anticipate in terms of like kind of fear and lots of questions that might affect the entire vaccination thing? And just like kind of, it's not like it's not even an issue of like what's scientifically right or wrong. It's just like so much of the acknowledgement that science is complicated, and that the public health messaging and public fears sometimes are so disconnected from what actually the science that is happening. And, trying to really be thoughtful around what could we get wrong if we convey something with this kind of language, and then also just like humility, being like, this is the way we decided to message this announcement. But if you guys feel like that's going to hit people the wrong way and there's a different way we could do it, we'd love to get that feedback. I mean, that's the kind of communication that is coming from the White House right now. And of course, it just couldn't be more different than what was happening, what was happening before, before January of this year. So there was just this, it's like just being enfolded in this like warm hug instead of like, there are times when you went out in the news media and you're just like, I don't even know what to say here, because it's like, I read a study and then the White House said something and then, all these reports, it was just like, it was so just like hard to know. There's a clip that a friend of mine took like after the White House presser where they mentioned like bleach as like a solution, and I think UV radiation. And I just started laughing, and somebody made that into a little GIF where I was like, I don't even know what to say or do question about bleach and UV radiation. And it was just like, there are these times where it's like, it's not just that we didn't have guidance. It was like, I don't even know what to address because we're not talking about science and like really nuances of messaging to the public in a way that makes them feel safe and understand how to behave and understand how freaked out to be or not to be. So there are just some of these fundamental changes. There are ways, even in like sitting in an academic center as a researcher, things have changed already in so many ways. But, and I think the other important thing is, health equity was an academic conversation until January. There wasn't really a talk about it, I have to say, that was meaningful. And it was like a kind of, lip service thing with no real solutions, no coordinated approach. And like, to have a COVID transition task force that didn't just include a health equity officer, but had one of the co-chairs, be Marcella, and have her be in the lead of that from the beginning, and then have that be a dominant part of every single conversation about COVID. It really gave me a year of my life back, of the 10 that I lost in the past year because of COVID and associated stressors. So, and I think we're going to see more and more of that, and just this recognition that because of the lessons from the pandemic, that health equity is in every single policy. And I think we're headed to a future where literally every department, whether it seems related to health or not, has a health equity officer. And so because we understand that everything, environmental decisions, everything really plays a major role in health and in health equity.
Great. I'm going to hijack the conversation a little bit. I was told that we can stay a little bit longer if people have more questions, but I wanted to also, Esther, take this opportunity to ask you, because we're a CLY, Career Life Yale meeting, I want to hear about how you developed your career, right? I mean, we were all trained in medical school, clinical training, you're an ER doc, but now you have a column in the Lancet and it's called Penumbra. What does that even mean? And how did you get that gig? And what triggered you to become a science communicator? Did your Yale education, did your English major contribute to this?
I don't know. I mean, maybe. I'm really surprised that I am, that there's ever a science communicator attached to my name, because I don't know, I definitely did not purposefully go after that, but I was an English major at Yale, and I love words and I love writing. And I kind of thought that I was making this decision to go into medicine instead of becoming a journalist or whatever I thought that I was going to be as an undergrad. It's actually kind of amazing that I made it into med school, because I had this roommate in college who's on this call. But like every time I had a test, she would put a novel. She would like leave a novel on my desk so that I would get derailed from studying or from writing that paper. It was so evil.
Was she a pre-med?
She was not. Oh my gosh, no. Edith was like a literature major and she thought I worked too hard. And so she would just like sneak these little like Maeve Binchy books or something that I just could not resist. And I would have to stop and read that. And it's like, that's why my grade point average is like, it was like at least a point lower because of Elizabeth Terry. But, you know, I think a lot of it was working in the ER and feeling like, too many people fall between the cracks, you know? So like, you know, I think I went down this kind of semi-journalism path and I was like, no, I really want to be directly helping people. And like the most literal manifestation of that is the emergency department. You know, people are like bleeding and things and you just put your hand on it. You know, you help fix people so immediately with such immediate feedback and gratification. So it was just like such a, you know, kind of a no-brainer for me that I like that environment and I really like acute care. But the more you're in the ER, it's like the things that were exciting about it when you go in become algorithmic and not that interesting. You know, so like cardiac arrest, stroke care, major trauma, those things are so algorithmic. You're kind of like, I'm not saying like you're not really there.
Not cardiac care, come on.
Well, I'm thinking of like resuscitation. Like our code's really interesting. You know what I mean? It's like 2 minutes epi. You know, it's just like, I'm not like, I'm gonna be super creative here, epinephrine. You know, it's like, it's so algorithmic. The time has passed and you need to give another shock. It's like, I can't bring creativity or really solve long-term problems, you know, and it really feels like in the ER, we are always doing care for like downstream problems. And actually what bothers you and what is a lot harder is like these problems with people not having basic needs met, you know, it's like all winter. I have a whole waiting room full of people who have chest pain and they need housing, you know, or we have patients come in and again in like a diabetic ketoacidosis because they don't have a refrigerator because insulin needs to be refrigerated and insulin costs too much. You know, the most basic medication costs too much. And so it's like people can't get basic medications. They can't get basic needs like a stable refrigerator that they can access twice a day to give themselves insulin so that they can stay out of the hospital, you know, from acidosis. It's like those kind of issues, like, you know, that I can keep on taking care of the diabetic ketoacidosis, same guy 3 times in 1 week. I have done this, you know, I can just do that my whole career and just turn my brain off and not care why that's happening. Or you can start to agitate for things like the Affordable Care Act, increase access to healthcare, better insurance, you know, universal health insurance, like the kind of very, very basic things that people need simply to stay alive, you know? And so I think that was really like my journey was being like, you know, I had patients who gave me a hug the day that Obamacare passed, you know, literally was like, I had patients crying that day because they could not meet their basic medical needs because they just could never get a primary care doctor who cared about them. And so, you know, things like that, I was like, all right, I may be just an ER doctor, but I think you need to start speaking up about that. And so then I got on social media and sort of got involved there. And then when you have opinions on social media, media finds their way to you. So I started writing more. And then eventually like made my way onto TV and did okay. And so that ended up being a big part of my pandemic work.
Well, so this is a room full of Yaleys. Do you guys know what penumbra means? I had to look it up. Tell us that story.
I can tell you, but I feel like there's probably like a physicist who can say it much better than I can here. But my husband's a
Wait, let's
radiologist.
ask the audience. Can
This
somebody
room.
explain? Yeah, this room. Can anybody define what penumbra is? Because that's the column that Esther has in the Lancet. Like, who
Right.
has a column in any medical journal? Nobody.
I have
So
to say,
who?
But-
David, go ahead. Frackleton.
That's right. That's right. So in radiology terms, in the old timey X-rays, there was the kind of the transition area at the edge where it was kind of where shadow turned to light, where there was kind of this poorly defined area. So the idea behind these columns, so Lancet basically said, we like your Twitter. I'm not kidding. They liked my Twitter. And they said, can you write a column on those issues that you address? So basically inequities, uncomfortable topics, racism, sexism, whatever it is that you want to talk about in healthcare, just bring that lens to a column. And I was like, I've never written on demand and I don't know if I can do it. And they said, just take one of your Twitter threads and just put them all together until it equals 700 words instead of like, 280 characters or whatever. And I was like, okay, I'll try. And so I did it. And I've been just agreed to do it for a second year. But it's been just like a really challenging and interesting and just a great forum to talk about some things that, that I've always wanted to talk about. And so the penumbra was just going to those places where we don't know a lot because they've been in the shadows. Topics like this, like racism and inequity in healthcare, we just don't spend a lot of time talking about it. There was just a study in Health Affairs that showed that I think something like in our major medical journals, 1% of studies mention racism, or less than 1%, I think. And most of those published articles are actually not studies, they're commentaries, And so we're all saying, you see these headlines, racism is a public health crisis, and yet we're not addressing racism in our science. We're barely mentioning it in our commentary. And so, it's because we have a fundamental discomfort with it. And when you're uncomfortable, you don't want to talk about it. And when you don't talk about it, you don't have the language for it. And if you don't have the language for it, you can't begin to solve it. That's where we are. So the penumbra was like, let's take those ideas, those areas that are typically in the shadows, and really bring them to the forefront, explore the penumbra, make it something that is defined and seeable and understood. So I think that title just kind of reminds me of like pushing myself to be a little bit uncomfortable in what I talk about and make sure that I'm staying in places that haven't been talked about a lot.
It's a beautiful series. I highly recommend for people to read it. And just to mention some statistics, you have 187,000 followers on Twitter. So you have a strong voice. You have a very poetic and beautiful voice, and we thank you for that. And I think it's typical for Yale's for you to have achieved what you have, and typical for the audience, so many of you who came up with the correct definition. So we are, beyond the hour. Maybe Jeff, should we take one or two audience questions, or do you guys want to just chat? Just jump in.
And
It's
also,
really, yeah.
I have to head off myself right now, but people stay great if they want to go, that's fine, but this was great, Esther. I really enjoyed it. Cheyenne, thanks for putting this on. YA really appreciates it. And the crowd here, it's great seeing the faces week to week. We'll see you again next week.
Thank you for all the organization and support. It was a lift behind the scenes. So thank you.
Keep going if you like, it's great.
Great, thank you. Thank you. Follow Esther True on Twitter.
Thank you, everyone.
Thank you. Okay, bye-bye.
Bye.
Bye.
Great job, Esther.
Thank
Go
you,
Oregon.
Thanks for putting it on.
Here, here.